Sawadee Krap. I'm very honored to be here, and thanks to the committee of the RjColoMIS2024 MRS conference, and especially the President and the RjColoMIS2024 Hospital. Today, my topic is about ERAS in the colorectal cancer. So this is my hospital, the Penlong Hospital, one of the largest private hospital in Yangon, which is about 200 bedded. I have no disclosure. So enhanced recovery after surgery program is initially pioneered by the Professor Henrik Hilek from Denmark, and he first established a group collaboration in 2000, and the first ERAS guideline was published in 2005. Then it evolved, and ERAS pathway ERAS program is not a stunt of the daring surgeon. It can apply to all the surgeons for the safer and quicker recovery for all the colorectal patients. So it is an evidence-based one, not a stunt one, and it's designed to reduce the perioperative stress, maintain the post-operative physiological function, accelerate recovery after surgery, reduce the rate of morbidity, shorten the length of stay, and it optimizes the use of the health system resources. So those are the evidence. I usually, this presentation rely on those two guidelines, the 2018 ERAS guideline and ASER and SAGES guideline in 2022. So it usually contains the full section, this pre-admission period, pre-operative period, and intra-op and post-op care. So that in pre-admission, one of the most important factors is to give time to the patient and explain all the clinical milestone and discharge criteria, what will the patient will experience in the surgery, and it markedly reduces the stress of the patient, and the patient will understand more about the nature of surgery, what will be facing in the pre-op, intra-op, and post-op period, and it causes the less metabolic response, less pain measure, and it has a very great advantage. So our target is for the colon operation. The length of the hospital stay should be around 3 days, and for the rectal cancer surgery, it should be around 4 days. In pre-admission, another important thing is the stoma teaching. So if you plan to do a diverting stoma, or even if the patient have the permanent stoma, the patient should have the stoma training in the pre-admission period. And it is very beneficial for the patient to stop smoking 4 to 8 weeks before, and to have the excessive alcohol stop at least 4 weeks before the surgery. Anemia is one of the important criteria to think in the pre-admission period. Most of the patient may present with the anemia, so although the patient may have not the ideal anemia state, the minimum hemoglobin should be between 6 and 10. So by understanding this, the patient may not have the unnecessary blood transfusion, and it can avoid all the transfusion risks. But if the patient have some huge comorbidity like the cardiac, renal, and pulmonary problem, the minimum hemoglobin should be more than 8 grams per deciliter. So this is the 2018 guideline, and the yellow color is a weak evidence, and the blue is strong one. So you can see the length of the graph show the low, moderate, and high. The high recommendation mean that the benefit of the measure is markedly outreach the disadvantage. So it means the high recommendation means that it has a very big advantage for the patient. Another one pre-op measure is to avoid the prevention of nausea and vomiting. Sometimes the surgeon usually think that it is just a small matter, but for the patient it might be a big factor for them. Especially the female sex, young age, history of nausea and vomiting, motion sickness, they should have a preventive measure for the nausea and vomiting. Another big topic is about the mechanical bowel preparation. So in the older version, they don't usually recommend the mechanical bowel preparation for the colon surgery and fleet animal for left-sided anastomosis, but MBB may be useful for the rectal surgeon. But in 2012, American and Sages guideline, they said MBB combined with the oral antibiotic is recommended. This is the new recommendation in 2022 ERAS guideline. So MBB with oral antibiotic is recommended before the elective colorectal resection. Another factor in the pre-op item is to reduce the fasting time. So by reducing the fasting time, the patient may have more satisfaction and less metabolic effect. And so we will allow the patient to eat the solid food even up to the midnight before the patient sleep and clear fluid 2 to 3 hours before the surgery. So evidence shows that there is no significant difference between the gastric residual volume and pH, and the patient may have a big satisfaction without compromising the risk of regurgitation and pulmonary aspiration. Carbohydrate loading is another factor. So we want the patient to come to the operation theater not in the fast state, but in the metabolically fat state. So carbohydrate loading is also recommended. So patient should drink the energy-rich carbohydrate fluid, 800 ml bedtime the night before the surgery, and 400 ml until 2 to 3 hours before the surgery. This is the intra-op measure. So another important things to evaluate to do the ERAS item is to use the minimally invasive surgery as much as possible. That's why we are coming to here to learn more and more MIS surgery from the international expert. So MIS surgery is more beneficial than the open and is easier to follow the ERAS guideline with the MIS surgery. Those are your team should also involve in the ERAS guideline, that the anesthetic protocol, they should use a non-opioid. And in the intra-op period, your anesthesiologist team can focus on not to get the hypotension, even not to lower the mean arterial pressure less than 65 millimeter mercury. If the hypotension is encountered during the surgery, it might affect your myocardial injury and even the acute kidney injury. So this is one of the important factors. So the surgeon may operate, your anesthesiologist may focus more on those euvolumia, pain control, less opioid, and to avoid the hypotension. So in the post-op period, the routine use of the nasogastric tube and intra-abdominal drain is not recommended, and it's better to be avoided. And avoid the prophylactic abdominal drain, but this is, I think, it's a big topic. For me personally, I routinely use the intra-abdominal drain, and I found many pictures with the abdominal drain after the surgery, but ERAS guideline don't recommend it, so it's a big topic to discuss. So enteral feeding, yes, the patient should eat as soon as possible. You can allow the patient to drink the clear sip 2 hour post-op period when the patient is fully awake, and the regular diet following in the post-op day 1. And the practice of the shunt feeding, like you encourage the patient to eat the chewing gum, it might fasten the recovery of the bowel function, and maybe the next day the patient may have a full diet program. Early mobilization is also an important factor in the post-op period. The patient should dangle their leg on the day of the surgery, and patients should eat all of their meat in a chair, not on the bed, lying. They should sit as soon as possible, and the patient should ambulate every 4 to 6 hours each day. So it means that the nursing care of the patient is also a big factor for the ERAS. So early and progressive patient mobilization is associated with the shorter length of stay in the hospital. Urinary catheter, also we don't want any of the tube unnecessary in the colorectal cancer patient, so urinary catheter should typically be removed 24 hours. in both in the colon and rectum surgery. But if the patient has some kind of cardiac problem, renal problem, and if you need the urine output monitoring for the fluid management, yes, it can extend to 24 to 40 hours after surgery. This is another fact, so I'm going to skip it. The key is to maintain the normal volumia all the time. So discharge criteria is, as I told you earlier, the colon it should be around 3 days, and for the rectum is 4 days. Although everyone now start to follow the ERAS guideline, there may be some limitation to do the fully ERAS measure in the patient, especially in our country. The patient have big norms, and there are a lot of barrier and resource limited country. Sometimes the patient don't want to, sit up. They don't want to eat early. They refuse and things like that. Even if you try to mobilize the patient think that, oh, that surgeon is torturing me or things like that. So it is a bit difficult to make fully ERAS program. And another limitation is the host resource limitation. Sometimes you need additional instrument, additional training and expert to fully implement the ERAS program. Sometimes it has a barrier, and another one is a time factor. So in our country, the surgeon had to see a lot of patients. Sometimes time is also one of the big factor. So you spend less time, and sometimes you fail to explain about all the advantage of the ERAS to the patient. Another one is the administrative support. If there's a lack of administrative support, it is difficult to perform the ERAS for your patient. Although there are some limitations, there's very clear message that ERAS can shorten the hospital stay, reduce the pain, faster recovery, and improve the patient satisfaction. So I evaluate my practice, and I try to follow some of the ERAS, and in some of the ERA, still need to improve. But for regarding the drainage, I routinely use it because it is not only for the prophylactics. Sometimes you can get an early diagnosis. You can get the reactionary hemorrhage, the minor leak problem. You can easily tackle with the drain. So personally, I use the drain as a routine.
Sao vậy ạ? Kenali. Kenali ya. Tahu di toa. Ya biar.
Although I'm not
Tahu.
Thank you very much for your kind attention.
Any question from floor? Okay.
Preoperative care is also important
Wait a
thing.
minute. Wait a minute. I have a question from Professor Myo. About the ERAS protocol. One of the criteria that you use is early discharge, right?
Yes.
So, could you share your discharge criteria before discharge the patient in ERAS protocol?
Yes. The latest guideline in American guidelines that even before the patient have full bowel function, there's some evidence that you can discharge the patient home. But for me, for my experience, if the patient is stable, can eat some soft diet, can walk, and I routinely check the CRP on the day 3 morning. If the CRP is normal, then I'm ready to let the patient go home.
Thank you very much. Thank you for nice presentation.
Thank you.
Thank you very much, Dr. Myo Thet.
One question here.
One question.
Thank you for your presentation.
Thank you,
Only
Prof.
a very small question related to the MVP. Because in my experience, since the 10 year, I didn't do the MVP for any colectomy. Until now, I have around 1,000 case like that, and we have no difference between the anatomic leakage compared to the other more 10 years ago. So how about your opinion in doing the MVP? You do MVP for on?
For me, the right-sided colon cancer, I never do the MVP. But for the left colon, yes, I did. And for the rectum, definitely I do.
Okay. And Chairman, you do the MVP
Me?
for left colectomy?
For the left side, I select some case. The case that I select to do bowel preparation is maybe small or early because I cannot define it on during laparoscopy. Even, but they have preoperative tattoo or localization by any kind. Maybe I skip the mechanical bowel prep. But for the rectum, in my opinion, I routinely perform MVP for the rectum.
Okay, thank you. Thank you, ma'am.
Thank you.
Thank you very much, Dr. Myo Thet Aung. Next, we have Dr. Luxman. Oh, sorry. Oh, question. There is one more question for the floor. Okay.
Thank you, Dr. Myo. Thank you for your good presentation. I have one question. Usually, do you use oxygen therapy post-operatively for good anastomosis prevention of leakage? No. Okay. So some cases in colorectal surgery, we usually use rectal drain for prevention of leakage. Do you use rectal drain as a routine? Or you use only 24 hours? So what is the reason of rectal drain used only for 24 hours for decompression? So we usually use about 4 days, average 3 to 4 days for once bowel rectum, peristaltic rectum, we can remove then only we can remove the tube. So your removal of rectal drain is very early, only 1 day, right? So if we, I see, thank you. So if you use, if we use rectal drain for more than 1 hour, more than 1 day, so how can you mobilize the patient? So that's why you remove. Thank you very much.